very high cure rate. And, with this, my personal opinion, and I can't say 100% we really think that tissue is probably thymic rebound.
The yellow one?
Now, this stuff right here. But here at the rim of the tumor, there's a little bit of metabolic uptake. Now, same thing here out at the rim, although this was not really above the background. This looks like it's a little bit above the background. Now, the bright stuff is where we expect this right here looks like thymic tissue that is rebounding after chemotherapy. But so this is not as where that looks like thymic rebound, but a little bit of a rim right here as we get to that tumor, that's a little bit above the background right here. And, I think there's two ways forward. And I do think at least sitting down with the radiation docs and going over this is definitely indicated. I think history has kind of told us, at least in clinical trial, this is not likely. Still, lymphoma, but it's hard to say. It's a little bit, I'll say, I don't even say it's a coin flip. I think it's not likely to be that. But, should we really consider, again, if this was 2000, we would have routinely said, once you finished up the chemotherapy part, we call it involved field radiation, where they contour to cover that area. But that was one of the bigger reasons we pushed the more aggressive chemotherapy. Because it's sort of that in-betweener. This could very well be just thymic tissue, and we can definitely, I would say, this other stuff, this is definitely thymic rebound right here. But as we get to the tumor portion, we still have a little bit, again, it's mildly above the background. And it's a little bit more than it was there in January. Now, what goes against that is the actual mediastinal mass has continued to retract and get smaller. So that's not suggestive that there's active tumor that all of a sudden is getting bigger. But I don't know what the exact right answer is. And I think we should at least talk with the radiation docs, because we had a sizable tumor. Tumors over 10 centimeters, historically, say if this was Hodgkin's lymphoma, we would be recommending, because we know in Hodgkin's lymphoma, large tumors, chemo doesn't penetrate it as consistently, and they're certainly at a little bit higher risk than smaller, bulky tumors of having a relapse within that bulky tumor. And we'll routinely use low-dose radiation, we call it involved field, to consolidate. So lymphomas can be very radiotherapy sensitive, and typically much lower doses than we use, say, in breast cancer, lung cancer, head and neck cancer. That requires pretty high doses of radiation. So there's sort of conflicting aspects, and I would certainly say it's gotten smaller, and that's what we expect over time. But there's a little bit more wisp around the tumor. That's a little bit above the background. And I think that's true. This stuff right here is thymic tissue. And that's kind of bright. And that that's a little more clear. But this, a little wisp around that, compared to January, that could still be thymic because this is this lymphoma arises out of thymic tissue. Primary mediastinal, they often have in that title, primary mediastinal thymic B-cell lymphoma, is sort of the long-winded one. But the two things that we saw here
Previously.
in the mediastinal, they're not there anymore.
No.
So that was different because that really wasn't part of the tumor, and I think that was just reactive. I don't know, we were after chemo, reacting to some respiratory, but that part no longer is present. But what we are seeing, we're certainly seeing a component of thymic rebound, but a little bit around the tumor, and even the report is kind of like hedging, decreased size in the anterior mediastinal mass. However, there's some residual hypermetabolism, and we look at DeVille scores. So metabolic uptake above background is sort of DeVille 4. And that's what they would call that DeVille 4, indicating the potential for residual disease with partial response. However, the mild interval decrease in metabolic activity may be attributed to thymic rebound. Certainly consider short interval follow-up, in the sense of if something's growing, that's our most worrisome part. If something starts growing again, that would be very, very suspicious. The mediastinum is challenging, particularly for people under 30, is we expect them to have thymic tissue. So if that was you, we wouldn't be thinking, oh, this is thymic. No, you shouldn't have any residual. But young adults in their teens or 20s are certainly going to have thymic tissue. And after big, particularly hematologic insults, or where their bone marrow is having to recover, we can see that kind of thymic rebound.